This is ACR QD Clinic, and I'm Jack Cush with Room Now. QD Clinics is brought to you by Room Now's coverage of ACR Convergence 2023. We'll be there in San Diego reporting. Hope you follow us. Today's case is the fainting OA patient. 68 years old, history of knee OA. Comes into the emergency room as she had an acute syncopal attack while shopping. On presentation, no chest pain, dyspnea, palpitations, nausea, vomiting, no recent illness. She has a past history of knee OA, a TIA last year. She's got AFib, and she's got diabetes. She currently takes medicine for her diabetes. She's on an albumetone, and she also takes warfarin. So when she presents, she is orthostatic. Her blood pressure is normal, but she does change with position. She has no belly tenderness. Her joints show OA, and she has blood in her stool on further examination. She is anemic. Her hemoglobin's down to 9.2. You don't know what it was previously. And clearly, this is someone who's at high risk for peptic ulcer based on taking a nonsteroidal, based on being older, based on also being on a blood thinner. And the question is, how do you manage this? And, this could turn into a multiple choice question, but the answer is you obviously stop the nonsteroidal, you hold the warfarin, you put her on a proton pump inhibitor, and you move forward. She's also taking Tylenol, acetaminophen, and the general rule with acute bleed is you stop the acetaminophen as well, because that can contribute and potentiate the problem, especially if they're on a blood thinner. So there are a number of things to talk about here that are important. Back when I was a fellow, and when they were developing drugs like misoprostol and COX-2 inhibitors, the advertised number was that nonsteroidals were responsible for 18,000 deaths per year, over 100,000 hospitalizations and over 18,000 deaths, and that could be avoided by either using a protective agent like misoprostol or using a more selective nonsteroidal like at that time Vioxx or Celebrex, and then knowing when to use a PPI. What I've noticed in the last decade is that nonsteroidal prescriptions are way down. Interestingly, maybe not worldwide, but in developed countries, the incidence of peptic ulcer disease is way down as well, or trending down, I should say. And I think that there are multiple reasons for that. Maybe we don't write as many prescriptions for nonsteroidals, certainly as specialists, and I think even primary care doctors are writing fewer prescriptions. Secondly, there's greater recognition of Helicobacter pylori and its contribution to peptic ulcer, and its earlier identification, treatment, etc., I think leads to better avoidance of this horrible complication. And then lastly, more over-the-counter and widespread availability of proton pump inhibitors like omeprazole, etc., has probably contributed to this going down in developed countries like the United States. But the second problem here is managing pain. I noticed that our fellows and residents don't write prescriptions for nonsteroidals, nor for opioids. That makes sense given the opioid problem and epidemic, but how is the patient's pain being addressed? Everyone will say, well, acetaminophen doesn't work. Tramadol is as good as placebo, and it's got addiction potential. I don't know if I agree with any of that, but I do know that we're probably very inadequate in managing pain. Again, treating the underlying disease, managing inflammation, getting to the core of the problem can help alleviate the need for pain medicine. But I think overall, we're not managing pain. But then again, being aggressive, using a lot of nonsteroidals may increase the risk, especially in high-risk people. You know who they are, right? They're the elderly. They're people who had prior ulcers. So maybe the bottom line is the elderly should not get nonsteroidals. And anybody who's had a prior ulcer or a real good suggestion of a prior ulcer should never get another nonsteroidal, even a selective one like celecoxib. And the question is, do we in fact practice that way? So we do know, for the most part, chronic PPI use is safe, especially when needed and used in high-risk patients. High-risk patients would be people over 60 and people who have symptoms, people who are using the drug chronically. Again, I would reiterate that if you had a prior ulcer, you should never get a nonsteroidal. Meaning I would never give a nonsteroidal plus a PPI to someone who wanted it if they really did have a prior gastric or duodenal ulcer. Sorry, just won't go there. It's too risky. I think when I can, I lessen risk by using PPIs, by using COX-2 selective drugs like celecoxib. And then lastly, minimizing dose is probably your last tool of defense. That's it for this QD clinic. Remember, we're going to be at ACR, and the one thing you want to do in trying to get something out of ACR is follow our podcast. Our podcast channel is going to be rife with content. Every day, starting Sunday, we'll be putting out a daily podcast of our faculty reports. There'll probably be at least 2 podcasts a day when that happens. Secondly, every day we do a daily recap panel that becomes a video and also becomes a podcast. That's at the end of every day, day 1, day 2, day 3, day 4. Also, there'll be topic panels that will occur towards the end of the week, starting on Tuesday, Wednesday, Thursday. So there'll be a podcast, for instance, on spondyloarthritis, or a podcast on JAK and TYK2 research. There'll also be topic podcasts, which are not the panels, but reports that will compile into one podcast. Any report that was on RA will go into an RA topic podcast. And the last podcast you'll find on Room Now is going to be the end of the week, next week, the Friday rheumatology roundup. Artie Kavanaugh and myself. I think I gave you the wrong time yesterday. That's going to be at 12 noon Pacific, 3 p.m. Eastern. We're going to live stream it, or you can just pick up the podcast or the video on the website and watch it that way. Tune in tomorrow for our last ACR QD Clinic.